just start sharing my slides. So my name's Liam. Thanks very much, Mahoney, for letting me come along and chat. Actually, unfortunately I haven't been able to join many of the sessions, clinical workload and things such as that. But I work down in St Michael's in Bristol, having trained mostly in the southeast of England and done a research fellowship in neonatal hemodynamics as part of the NeoCirculation trial, which was kind of the, I don't know, brother trial, I guess, to the hypertension in preterm infants trial headed out of by Eugene Dempsey's group in Cork. We did an equivalent kind of trial in dobutamine, but we didn't get as far, unfortunately, as they did to actually conducting the randomized control trial. I think what I wanted to talk about this particular session was a bit more, I suppose, a bit about because there has been some evidence which has come out recently around, the use of inotropes, vasopressors and lusitropes, etc. I just thought I'd explore that in more depth and a bit more in depth about the drugs that we currently do use, and a bit about the evidence that exists for them, and a bit about perhaps actually some of the dangers behind some of those drugs as well, and some of the unknowns that we need to look at. And I wanted to spend a bit of session actually spending a bit of time from what we did back in Brighton, looking at inotrope delivery and inotrope stability as well, because there was some interesting data which came out there which changed practice, and I just wanted to share that with you guys, if that's okay. Can I just check, can everyone hear me okay and see me all right?
Yeah, all good.
Okay, I'll crack on then. So I suppose, as everyone's probably well aware in this group and interested in, is that, shock, circulatory failure, whatever you want to kind of define it, it's a state where, the circulatory function is inadequate to meet the tissue oxygen demands of the tissue. The treatments, it is controversial because there's no agreed definition. The most common one is a mean blood pressure equal to your gestational age, but as we know, that doesn't necessarily tell you much about the etiology. It doesn't actually ring true for babies kind of outside of the first 72 hours of life as your blood pressure naturally goes up. It's also a really difficult area because there's a lack of research in this area. And actually, research is generally confined to preterm or very preterm infants. And we know that we deal with a range of babies. Late preterm infants' cardiovascular systems are developed differently from that of a very preterm and that of a term baby. So actually, the way that they react to inotropes and treatment is different. And also, with somewhere that lacks clinical evidence, you're going to get a wide variation in clinical practice. And because you're dealing with the sickest infants using very powerful drugs, it's very, very difficult to get research and to develop an evidence base. But there has been call for research in this area, and the European Union, there was an FP7 grant which went out probably around about 2015, for which two trials, one based in Cork, which is the hypertension and preterm infant trial, which was looking into neonatal formulation of dopamine, as well as looking at dopamine versus saline as a randomized control trial, and NeoCirculation, which came out of Brighton and worked with Madrid as well, was the equivalent for dobutamine as well. And they, unfortunately, we've all seen in archives Eugene Dempsey's trial, some of the data that came out there and how they had to end that trial, unfortunately, early. And unfortunately, the dobutamine trial, the NeoCirculation trial, also came into similar problems, but didn't make it as far as the randomized trial, as I mentioned previously. I'm going to go straight into really talking about the inotropes, if that's okay, and talking about the evidence and where we are and what's been happening lately in terms of some of the evidence that's come out around some of the inotropes and where they may fit in for treating infants with cardiovascular compromise. But I think it's good to, before going over the latest evidence, is to have a look at how many trials that there have been. And if you look in the 1990s, there's about 10 trials, a maximum of 63 patients, and nearly most of the trials all looked at dopamine versus another. Well, they did basically look at dopamine versus another drug, most commonly dobutamine. And generally, all of these trials were looking at measurements of blood pressure. and not really much else, maybe some biochemical markers. But also, as you can see, that the types of infants that were enrolled were quite wide in their, not only just being on the terms of their gestational age, but also their weights. If you have a look at from 2000 to 2019, again, and similarly, around about 10 trials have come out. And whilst it's a bit more varied in terms of the agents that have been looked at, most, again, have involved the use of dopamine versus dobutamine. But there have been other trials which have extended to looking at dopamine versus hydrocortisone or versus vasopressin, or versus adrenaline as well. And there's been a couple of trials which have attempted to look at various agents versus placebo as well. But similarly to the previous trials, small numbers and also difficulty, and also a relatively wide range of infants enrolled into those trials. This is just another slide which looks at most of those trials. Again, this comes from Frontiers in Pediatrics. What I think it nicely does is not only outlines the different kind of agents and what the populations, but it just goes to show that whereas some research, if you're looking at outcomes like long-term neurodevelopmental outcomes, you've got things like Bailey scores, which are almost universally used across those trials. Whereas if you have a look at this particular research, it's very different. You've got lots of things using measurements of cardiac output, cerebral perfusion, blood flow, GI perfusion, even lactates as a biochemical marker of cardiovascular health, and it really varies. So actually, it's quite difficult when you're looking at these trials to create systemic reviews, or I guess even do some sort of basic meta-analysis, because actually the outcomes are very widely differently reported between the different trials. And so it makes it difficult to look at those short-term outcomes in terms of perhaps those echocardiographic markers of cardiac output. But more importantly, really, none of them have long-term data, which is what we really want to know about in these particular infants. But there has been some studies now which have hinted at indications of inotropes in particular scenarios may be beneficial over others, for example. And I'll talk a bit about that. So I'm going to quickly go into the inotropes really and talk about what's happened with them, what's happened with the evidence that's happened. I'm not going to spend too much time on these slides because I feel I'm talking to everyone who knows how these drugs work and what they do. I'm looking at dobutamine, which is been around for quite a long period of time now, mainly as a beta adrenergic activity, and mainly increasing your cardiac output and mildly reducing your systemic vascular resistance. In summary, the trials have really shown where it's been looked at, and all of the trials near enough have looked at dobutamine versus dopamine. There's been one trial which looked at it versus placebo, has shown that it's superior at increasing systemic blood flow, however you measure that in preterm infants. And most of that trial data came out of Australia. It's come out from Martin Klucklow's group, Nick Evans, David Osborne, where they've had a look at, my slide's going all over the place, where they've looked at this is the randomized control trial that they did, where they compared it using SVC flow, and I think they looked at LVO as well. But what they found is that if you're looking this as a marker of cardiovascular health, that certainly dobutamine, if you're looking, using a baby as their own control as such, that you will, at dobutamine at 10 and 20 in comparison to dopamine, will preferentially increase your superior vena cava flow. As part of the near-circulation trial, there has been a more recent trial in 2015 looking at dopamine versus placebo, looking at SVC flow, looking at outcomes, for example. And there were very few patients, again, a total of sort of 28 patients brought in here. And when you look at the p-values, whilst some of the p-values are in favour of the use of dobutamine versus placebo, for example, mortality, if you see on the far right, or serious ischemic events, for example, No real conclusions can be kind of drawn from this, and furthermore, there wasn't any long-term data from this trial, but certainly in the short term, if you're looking at SVC flow, it did kind of normalise it better than obviously using placebo, which makes sense. But in terms of deriving sort of long-term outcomes, this trial wasn't powered to do it or didn't actually do it. I'm going to have to go back a couple of slides because I've been in the wrong order. But one of the things that we have tried to do as part of, again, the near circulation trial, which I was a part of, was to try and get an idea of what was the half-life and what was the clearance for babies. Because one of the things that we really don't know about many drugs in neonates is pharmacokinetics and pharmacodynamics. And the only real conclusions we could draw from these 10 patients, and this was a bespoke dobutamine, which was made for premature neonates, is that one, it's very difficult, firstly, to get results about half-life. As you can see, about half the babies we couldn't get concentrations. But also the dopamine clearance and the half-lives that we got for this particular drug really widely varied between those infants who are of a relatively similar gestation, which really goes to show that, these drugs which are powerful, we really don't know still, and we still don't know from the data that we've got so far. One, we can't make any conclusions about their half-life or clearance. But furthermore, it just shows that we probably know very little still about the neonatal the neonatal pharmacodynamics and pharmacokinetics, in the sense that depending on your gestational age, for example, this will vary greatly. So I suppose the next thing I wanted to go on to was to talk about dopamine, and I kind of feel that dopamine, if you look on Twitter, various different pages and things like that, is beginning to go out of favour. And I certainly sort of kind of sit in that camp of that dopamine is a drug which can have harm, but is also is also a drug which kind of does a bit of everything. And if you're using it, maybe it's not the best drug because it's a bit of a dirty drug, in the sense that it does lots of different things. And there are some well-documented side effects from dopamine which you need to watch out for. But I think one of the reasons that dopamine is like that is probably because it's the most widely used drug. It's the one that we have the most data on. It's the one that's been most well researched. So in a sense, I kind of feel at the same time, we can't completely push it to the side and say that it's an awful drug. It's just the drug that's been well researched at, if you compare them all. And so actually we know more about its harms as well as its benefits, I suppose, in a way. But what do we know about dopamine? Well, we know it does lots of different things, in that it has lots of different effects on lots of different receptors. And that generally, when you amalgamate all the research together and you look at it, it will increase your blood pressure better than dobutamine. It will increase your superior vena cava flow to a lesser degree than dobutamine as well. And if you compare it to the one other drug that has been looked at in a randomized controlled trial, which is adrenaline, they're equally as good as improving your blood pressure. Sorry. And this is, I suppose, the data which comes from Eugene Dempsey's group, which is the trial which they did as the hypertension in preterm infant group. And when you compare it to placebo, it's unsurprising in the fact that it does increase your mean blood pressure if you're comparing it to placebo. But one of the things that they pointed out is that, interestingly, over the first 120 minutes of life, those who are on placebo, which was a saline infusion at the same rate, I believe, you're going to get a natural increase in your blood pressure. And Eugene Dempsey has done a lot of work in the idea of permissive hypertension and things like that. So really challenging the thought of using blood pressure as whether this is a completely valid marker of cardiovascular health. As I said, the one thing about dopamine, I think why people are worried about it, is because it's been shown to have some negative effects. It can suppress your thyroid activity, in particular in preterm neonates, and there's been some papers which have looked at follow-up from thyroid activity in neonates, which is depressed for a period of time. It does go back to normal, but there are concerns around how that may affect neonates in terms of thyroid hormone being relatively important, certainly in utero for growth. Maybe not, and important certainly in the first year of life. Prolactin production is also altered quite markedly, but in terms of that effects in the neonatal, I'm not sure as to the relevance of that or whether it would have long-term harm. And I think one of the things that we worry about in particular in certain pathologies like PPHN is that animal studies have certainly shown that it can increase your pulmonary vascular resistance. And so, in PPHN, in neck aspiration, in babies who are quite septic, who may have raised pulmonary pressures, the use of dopamine needs to be done, needs to be cautiously, using dopamine needs to be done with caution. There are lots of things that still floating around the place about renal doses of dopamine. I'm not aware of any research, and having looked in the literature about it existing. And actually, there's a really interesting blog from Keith Barrington, which I've linked here, and I'm more than happy to share these slides, where he talks about the renal dosing of dopamine and where it comes from. And actually, his group, and I believe it was animal studies, that they did this on when they measured renal blood flow. When they measured that in animal studies with dopamine versus adrenaline, actually they found that adrenaline was better increasing your renal blood flow in comparison to dopamine. But I'd follow that link and I'd go read that because he's very eloquent in how he writes about research. And this is another post which is really good, which kind of dispels that myth of a renal dose of dopamine. And this is again from the animal studies, which I spoke about your comparing your pulmonary arterial pressure to MAP, and what is shown here is that if you use dopamine itself versus a placebo, you tend to get a quite marked increase in that ratio, and so that is of concern in neonates where you've got raised pulmonary pressures. But just be aware that this is also animal data. I wanted to move a bit on to about noradrenaline because there's been some interesting research which has come out relatively recently looking at noradrenaline, which we know is a potent vasoconstrictor, but does have some effects on your heart rate, so may increase your your systemic blood flow as well. And there's been lots of retrospective studies, and it's never been actually subject to a neonatal RCT at all. It's been looked at in particular in two kind of settings, neonatal sepsis, but also in the context of PPHN as well. And if you have a look at some of the retrospective studies as well, which have just looked at the increase, what happens when you give noradrenaline over a period of time with those neonates, if you have a look at their blood pressure, yes, it markedly increases your blood pressure over the first 8 hours of life. It increases your urine output quite markedly as well. It also decreases it can lead to a transient increase in heart rate, but presumably as a baby gets better from a cardiovascular point of view, you see an eventual decrease in your heart rate. But in terms of other biochemical markers such as pH and base excess, they both improve with the use of noradrenaline, but also your FiO2 has been shown to come down as well. Now, when you and similarly, this is another study from the European Journal of Pediatrics, which kind of just really reflects the changes which Risketall found in Acta Pediatrica when they looked at a cohort of infants who were given noradrenaline as a single agent. And in this particular group by Radcliffe, they found similar improvements in those parameters as well. There was, and part of this, the interest around FiO2 as well, and the decreases in FiO2 led to a French group looking into the use of noradrenaline when you're looking at it in PPHN, and they found this in babies who didn't have, I can't remember exactly what their oxygen indices were, but they were babies who had persistent pulmonary hypertension of the newborn. They were late preterm to term infants who weren't particularly unwell if you're using oxygen index as your marker of how unwell they were. But what they found, and again, this is a ratio of mean pulmonary arterial pressure to systemic arterial pressure as a ratio. What they found was that with the giving of noradrenaline is that you saw a beneficial effect in that ratio went down. So your mean arterial pressure is going up at the same time that your pulmonary arterial pressure is going down. So, if you're looking to try and fight the shunts across a PDA, for example, that right to left shunt, that this might be a preferential agent in that. And that's led to some people perhaps think that actually it may have an effect on a differential effect on your pulmonary artery pressure, and that there may be some factor with the alpha agonist effect that it may affect your pulmonary vasculature. But interestingly, working where I work in Bristol, there was Prof. Robert Tullow, who's a professor of paediatric cardiology, who did a lot of, and his interest was pulmonary hypertension. And in all of his models of pulmonary hypertension that he used, all his animal research, he would preferentially give those babies baby piglets, for example. He would give them noradrenaline in order to induce pulmonary hypertension. So one of the thoughts behind this actually is that you may just get a preferential increase. You may get an increase in your pulmonary arterial pressure, but that pulmonary arterial pressure increase is more pronounced in your systemic system rather than your pulmonary system. And so therefore you get that preferential or that beneficial reduction in your mean PAP to mean SAP ratio, if that makes sense. But he's a paediatric cardiologist. He looked at it in different kind of conditions, mainly focusing on congenital cardiac disease, not babies who are premature and have maybe just the fetal channels which are open and not that congenital cardiac disease. But it was just a thought that's been raised around this particular research about noradrenaline and PPHN. I think one of the interesting bits that come out about PPHN, which I think is about noradrenaline, which is filtered down perhaps from adult intensive care, PICU, for example, where it's preferentially used in sepsis, for example, is an interesting study which has come out from, again, in the European Journal of Pediatrics, which came out from Canada, again, which was albeit a retrospective study, but had pretty decent numbers in comparison to lots of previous RCTs. And they did quite a lot of adjusted analysis for odds ratios. And what they found in this particular group, in that babies who were septic, who were given noradrenaline as opposed to dopamine, that actually they found that there was an adjusted odds ratio benefit for mortality, and I think in not only mortality but also subsequent long-term developmental outcomes as well. They found that those babies who are septic, who are treated with noradrenaline, did better than those who were in the dopamine group. One of the things that I'm aware of, is I talk quite fast and I tend to ramble through slides. So I just wanted to just pause for a second and see if there was any questions that anyone had before I went on to talk about kind of the last three inotropes before I go along to talk about drug delivery. Okay, silence. I'll carry on then. Adrenaline is, again, another agent which we know affects lots of different receptors and has lots of different effects. And, again, there's a thought at different doses that it'll increase your systemic blood flow. And at other doses, it'll cause quite a marked, a preferential kind of perhaps increase in your SVR. And it's been subject to one randomized controlled trial, and this was done from the group that I worked with in Madrid. So Prof. Adelina Pellicer's group, where they looked at it versus dopamine, and they looked at it over a number of hours, I think over 3 days, in babies who were needing treatment for circulatory failure. And they found that it was as good as increasing your blood pressure in comparison to dopamine. But those babies tend to have more issues with hyperglycemia, myocardial oxygen use, lactate levels transiently raised, and also more issues with arrhythmias as well. So this is from their trial that they performed back in 2006, and you can see there that apart from 2 time points at around about 48 hours of life, that dopamine and adrenaline, the mean blood pressure was the same in both groups. But if you have a look at what the issues that you have with lactate and glucose, they're quite pronounced. And actually that rise in lactates, whilst you've got to be wary of it. And actually it takes around about 12 to 18 hours before they found in this particular group, before that initial rise in lactate came back to normal. And similarly, I suppose in the glucose group as well, which they may have some relation, will have a relation with each other, because certainly adrenaline will increase your gluconeogenesis. It will also, increase your liver's production of lactate as well. So, last couple of inotropes to talk about. First is milrinone, phosphodiesterase inhibitor, which has a used quite most frequently, I suppose, post cardiac surgery in this kind of PICU setting, but is getting more and more interest in neonates, I suppose, in terms of not only in those babies who have had post PDA ligation syndrome. PPHN in particular, it seems biologically a very, very sensible drug to use, in particular in the fact that it increases your cardiac output, improves your relaxation, and also leads to a decrease in your pulmonary vascular resistance. It can lead to systemic vascular resistance reduction as well. So often, if you are going to use it, many publications recommend that you make sure that you've got a baby who's got enough fluid on board. And certainly one of the things that you would want to avoid using it is in situations where you have renal failure. For example, I think Dr. Geizinger from Iowa was talking about cases where they used milrinone in babies with HIE who had renal failure. Well, milrinone is almost completely excreted via your kidneys as an unaltered drug. So if you give it to babies who are in renal failure, it just accumulates, and therefore you may come into problems with with hypotension and needing to counteract that. Where it has been looked at systemically as part of randomized controlled trials is in two settings. Firstly, the group again in Australia looking at it versus placebo in very preterm infants. Because it seems, again, biologically plausible for a baby who in the first kind of 48 hours of life, who have issues with postnatal adaptation. We know from Nick Evans' research with SVC flow that your cardiac output tends to hit a nadir at about sort of 6 to 8 hours of life. And that's the thoughts behind using SVC flow kind of as repeated measurements in the first sort of few days of life in preterm infants. And that if that does get low, to use an agent which would help improve your cardiac output, because we know the neonatal myocardium doesn't react well to a big hike in SVR, which happens in the postnatal adaptation phase when you have the cutting of the placenta, and that actually something like milrinone would be beneficial. We know that premature neonatal myocardium doesn't fill very well. You have diastolic dysfunction. Milrinone helps that. Milrinone helps your cardiac output in those babies who perhaps do have a lower cardiac output in that postnatal adaptation. And also it does reduce your SVR as well. However, in those babies, and this is one of the bigger trials that had 90 babies in, when they randomized to placebo or milrinone, there was no kind of improvements in short-term outcomes or really apart from your heart rate, which was higher in the milrinone group, which makes sense. But there was no kind of short-term gains, and I think they went on to look at these babies in the long term as well, and there was no gains as well. One of the interesting things, and one of the trials that I would go and look at, is the MINT trial, because milrinone is, again, it's an agent that seems very appropriate for the use of PPHN in that it reduces your PVR whilst increasing your cardiac output and improving your diastolic function. And certainly from the research which was leading up to the inception of the MINT trial, which was done which was Fifel Kafesh from Dublin. Again, infusions of milrinone in babies with PPHN has been shown to reduce your MAP, reduce the mean amount of nitric oxide that babies need, improve cardiac outputs in measurements of RVO and LVO, does lead to transient drops in your blood pressure, but this does resolve in those babies. But unfortunately, I guess in the MINT trial, which I haven't got the slide here, they similarly found these improving trends in the MINT trial, but unfortunately, I think they only could get a very few babies. And what's really interesting about the MINT trial is that actually I'm going to read it to get an idea of the difficulties in performing research in this area, which I'll allude to later on. The last inotrope I'm going to talk about is the one that seems to be getting kind of a bit more kind of, I guess, press in the way. People are using it a lot more. We certainly as a unit in Bristol are using it a lot more now. And I've gone into a bit more detail about this because I've spoken to some people about it who want to know a bit more about it in terms of what we do know about its pharmacokinetics and pharmacodynamics. It acts by acting on your V1 and V2 receptors, causing vasoconstriction in the smooth muscle. We know its volume of distribution is about 0.14 litres, and that comes from adult data, and it is renally and hepatically metabolized. So you can use it, albeit with a degree of caution, in babies who have hepatic and renal dysfunction. And it's got a relatively short half life from adult data, and it is excreted via the kidneys. And you need to be aware that in renal failure, that a certain proportion is an unchanged drug, so it will accumulate in renal failure, albeit not as much as milrinone. We know that from the research that it increases, that most of the research which has been done retrospectively has been shown that it reduces the amount of inotropes that you need. If you've got a baby who's on 2 inotropes and you put in vasopressin, then you can come off those inotropes relatively quickly, and it does have a potent increase in your blood pressure. One of the things that you do need to watch out for is, because you're effectively giving that baby ADH in that antidiuretic hormone, is that you need to watch your serum and urine sodiums, and it can lead to hyponatremia in 3 ways. The fact that you have improvement of your renal function, and that you may get ATN, that you may get the dilutional effect from increased antidiuretic hormones. So in the distal tubules, or in the water collecting ducts of the kidneys, you may get increased reabsorption of water and loss of sodium. But also in babies who are given, I think it's animal models and adult data, it's been shown that the proximal nephron may adapt if you're given vasopressin for a period of time, and that it will lead to increased sodium and water excretion. So you become hyponatremic through kind of 3 different mechanisms with vasopressin. So that is kind of one of the things that we are learning more about with it. But what we're finding out is that certainly when you look at the trials and you look at it versus dopamine, in that you have in terms of, you're comparing the time to response in terms of to get an adequate mean blood pressure in treatment groups, that you got a similar response to dopamine. So it works in a similar time frame. It also, in terms of, if you look at the time from starts of vasopressin in retrospective studies, you can see that your FiO2 again goes down. And also you get reductions in your heart rate and increases in your MAP over that similar that period of time. And one of the things to say about vasopressin is also it can be a drug of choice in babies where you don't want to increase their heart rate. So babies who have perhaps so we used it, for example, successfully in a baby who, I think we did anyway, in a baby who had cardiomyopathy secondary to mum's gestational diabetes, which was refractory to treatment. And actually, because it didn't increase that heart rate but increased blood pressure, it was really useful because it didn't interfere with filling with that baby. There's also a thought that vasopressin may have an effect on the pulmonary vasculature as well, in that it actually may cause some vasodilation. And you can see various posts and various different publications will recommend it as a inotrope of use in PPH and PPHN, for example, or where you've got raised pulmonary pressures. And certainly when we talk to our local ECMO centre, which is Leicester, quite often we would get recommended to start vasopressin as well. But we're beginning to do that more as a centre ourselves in the first instance before talking to ECMO centres. I'm going to briefly talk about adrenoreceptors, and just to say that actually they very much, it's another layer of complexity to inotrope use and could be a separate talk in itself. But you have maturational, differences in your alpha and beta receptors depending on your gestational age. The higher your gestational age, the higher number you have. But also, it's just to say that you will get your beta receptors do increase markedly over the first few days of life, and just to be aware of inotrope use and actually the type of inotropes that you use, and when you will see, and if you're not seeing a response to a particular inotrope over, in the first 24, 48 hours of life, you may see one, a bit later on, because the beta adrenoreceptors do increase quite markedly over the first few days of life. And that's one of the rationales actually why you want to kind of use steroids, because steroids in terms of antenatally, but also postnatally, we've been shown to upregulate not only adrenal receptor expression, but also in studies where they've used dexamethasone either with babies who are on adrenaline or babies who are just given it for hypotension versus placebo. It's been shown to not only reduce the amount of time that you're on adrenaline, but also increase your blood pressure as well, which makes kind of sense and kind of is in keeping with data that we know about anyway from antenatal steroids. This is just if you want to know about drugs and you have a kind of photographic memory, that this particular slide from Wilhelm de Bude is really useful in trying to think about drugs, how they work, what they do, and it's a publication that I'd go back to if you're looking for a really good publication from pediatric research. I think it's from his echocardiography special edition, one from 2018, and it's a really good paper on the use of inotropes and the particular drugs and what they do. I'm just going to spend I realise the time. I'm just going to spend 5-10 minutes to talk quickly about inotrope delivery, because I think there's some data which we got from the NeoFOCUS group, which I'd like to share with you guys and talk a bit about. I mean, the first thing to say is I think we're all aware that your dead space in terms of inotrope delivery, in terms of catheters, is quite long. And we calculated this with a number of different inotropes, and we actually had an Excel spreadsheet for all the different dead spaces for all the different kind of IV catheters that we used. And for some of them, in the smallest babies, it meant a couple of hours before actually they got the inotrope, because they had to clear the dead space. And so some places will use, you obviously run it with certain infusions. There's compatibility issues, but you obviously want to run it with the fastest kind of infusion so that the baby gets the drug. And some places even have an inotrope port where they have a freeway tap put on in order to make sure that, you have a particular inotrope delivery mechanism which ensures that it gets into the baby as fast as possible. But one of the things that I wanted to briefly talk about is we did some research looking at inotrope delivery and what happens over the 24 hours. Because typically, I mean, we in Brighton, when I was working there, we were changing infusions every 24 hours. So this is a study that we did as a bench study where we made up infusions of dopamine for these different weight sizes in babies. I think there was 10 mics per kg per min. And basically we left them in 21 degrees, 28 degrees, and we made them up with saline or 5% dextrose, 10% dextrose. And then what we did was we used a technique called cyclic voltammetry, which is basically any drug that can be oxidized produces a current, and you can measure that current, and the measurement of that current is proportional to the concentration of that drug. And so over 24 hours, what we found that with dopamine in particular, not with dobutamine, is that actually, if you see these red lines on these graphs, that's the British Pharmacopoeia limits, which means that when you make up a drug, an oil infusion, you can be 5 to 10%. You can be 10%, sorry, either way. No, you can be 5.5%, sorry, either way of that desired dose out for it to be acceptable. But what we found is over 24 hours, that in particular in glucose in 21%, but in 28 degrees in either saline or dextrose, that dopamine degraded quite significantly over sort of a 24-hour time period. And we took that further to kind of replicate that in not only just with syringes on the bedside, but then we infused it through, we did a similar experiment, but put it through a syringe driver, put it through an incubator where the temperature changed from the outside conditions with the syringe driver through the tubing where it went into the incubator where we changed the temperature, which went set at 35 degrees, for example. And again, we found with dopamine that in particular with normal saline, that actually your change from baseline was really quite significant, and outside kind of the pharmaceutical tolerances that we allow in the UK. So actually over 24 hours, the period of life, the concentration of dopamine that you're giving, or that you think you're giving, is actually up to sort of 5 or even up to sort of 10% less than what you actually are giving. And what that led to in Brighton was actually, and they use Metavision, well, they do use Metavision currently, which is an EPR system where they recorded their blood pressures. And what they found in some patients, in the top graph, you can see, is actually over the period of time that they got this eventual drop where babies who are on dopamine, their mean arterial blood pressure, which was in red, they found that when they were coming to change syringes, they were getting spikes in their dopamine, and that might be, and this wasn't in every baby, but it was just in a few babies they noticed this. So what they've decided to do is, because of this data, they changed the syringes of dopamine every 12 hours, and they found that they were getting less spikes in their blood pressure around syringe changing time, which can be due to you getting a bolus, but also it's thought of dopamine, but also is thought to be perhaps secondary to the fact that you're getting a bigger concentration despite giving it at the same infusion rate, because of that degradation you get of dopamine. So that actually led to a change of practice there as well. I think I'm not going to talk about treatment protocols, because I think probably from reading this group and and being part of this group and reading publications which come out from this group, I think going on to a one-size-fits-all protocol with regards to drugs and how we use them in particular, and how we monitor the effects of those drugs, isn't appropriate. And I guess, we need to, part of drugs and talking about this is to feed into that kind of guideline, or that thought process about how we look at babies and how we go on to treat them with each particular drug. But I think, again, what is difficult and what is a shame is, whilst it is great to have an individualized pathophysiology hemodynamic approach, which I think everyone is advocating, everyone kind of aspires to do, I think what is difficult, and what is kind of one of the frustrations of creating a talk like this, is that the evidence behind is still lacking, and it's going to be difficult to create. And it's why I'd say, if you're going to read the MINT trial, actually, it's not necessarily about what they found out about milrinone. It's more about what Prof. Elkfresh talks about in terms of creating research in this area. And that actually, I'm just going to quickly move on to this slide, in that actually when we're creating trials and when we're thinking about designs for how we treat cardiovascular compromise in babies, it's going to be big trials which need to be done over many different centres, because enrolling babies into these trials are really difficult and can't be done out of a few centres. And I kind of feel like that an effort needs to be made in the same way that they did with the Beneductus trial, where they had so many centres involved, and that you really do need to kind of have quite a strict regime of how you're treating these infants, and not perhaps using one particular inotrope. You're using a physiological based approach versus perhaps a protocol based approach, which we traditionally use to look at outcomes. But again, that takes time. It means that for powering the outcomes, you're going to need lots of babies. And, these are babies who are the sickest of the sick. So you need to think about how you kind of enroll those studies and enroll babies into those studies. In particular, there is a bit more of a push now for deferred consent, but whether the ethics surrounding that is appropriate for babies who are the sickest of the sick. I finished with 9 minutes to go, I think. So I'm going to stop my slides there. And thanks for letting me talk. I hope to make many more of these presentations to engage with the group more and more, but I welcome any questions, and I'll stop sharing my slides.
Thanks, Liam. That was brilliant talk, and a very comprehensive summary of the evidence for the currently available vasoactive drugs. I think there was some question from Aaron on the chat about the assumption of the renal dose of dopamine at 5 mics per kilo. If you would like to elaborate a little bit more about that, please.
Yeah, I mean, it was. I think the renal dose of dopamine, I think it's come, the thought has come from animal data, if I remember rightly. And it's never been replicated in neonates. I mean, similarly, the one thing about dopamine is that actually the raises in pulmonary vascular resistance has come from animal data as well. So that's why I was saying I think we have to be wary to completely throw dopamine out the window. But I'd have to refer back to the Keith Barrington study, which he does a lot of animal research with, I've forgotten his name, I think it's Professor Chung in Edmonton in Canada. and he looks at inotropes, and he specifically looks at a lot of different inotropes. And I think one of their studies, they were comparing dopamine to adrenaline in, I think it was animal models again. And when they looked at renal blood flow specifically, actually adrenaline was better than dopamine. I don't know the doses though, so I can't elaborate on it further. But a lot of the data, but what I can say is that a lot of data around kind of dopamine for the benefits in terms of renal, but also the worries about its increase in pulmonary vascular resistance does come from animal data, which we just have to take with, we have to worry about that crossover to how we apply it to our population.
Mo has got your hand.
Hear me?
Yeah.
Hello. Hi, Liam. Thank you very much for the interesting presentation. I just one question actually. Have you noticed? I mean, while you go through the literature, have you noticed any difference in the dose range for epinephrine and norepinephrine between Europe and North America? Because I remember when I was in Canada, we were using only 0.05 up to 1.5 maximum on both of those. And if you need to go up that, they actually really cautious about the tachyarrhythmia and actually cardiac exhaustion and increasing lactate. So rarely we had to go more than 1.5. And I'm glad actually that you mentioned the hydrocortisone and that the steroids was and what's to do with the receptors. So have you noticed this difference? Because in the BNF, I think, the BNF, I think said 0.1 to 0.3 at least. And I think there is, and I remember when they were trying to recruit for the HIP trial, this caused a little bit of issue in our center when we were there because the dose range was higher than our guidelines at the time. Thanks.
No, absolutely. And I think lots of the literature says, if you're getting into higher doses of any inotrope, that actually you should think about inotrope, an inotrope kind of resistance, and that actually steroids should be, steroids should be the next logical choice if you're on kind of one or two inotropes. But I would certainly, I worry about noradrenaline and adrenaline as well, in particular, like you're saying, the myocardial effects of both. If you're getting into those higher doses, I know some people say that, with high doses of adrenaline, you're going to get the quite marked SVR increase as well. But I would then worry actually that you're going to cause, myocardial issues. And I think I can think of one baby who was extraordinarily sick that we had to give a lot of adrenaline because it seemed to be the only thing that they were that was working. But later down the line, that baby had issues with myocardiopathy, issues with their myocardium. And I can't help thinking that actually that's because we knackered the myocardium quite early on. Rightly so, because it was the only thing that was working. But then the side effect of that later on down the line was, unfortunately, issues with myocardiopathy of sorts. So yes, I looking at the literature, in particular the review articles, I would say they are, they would say that doses ranges, as you mentioned, of noradrenaline. That actually, if you're thinking that you need to go up further, then think about steroids. In particular, for example, in HIE, in particular, if you've got refractory well, not necessarily hypertension, or refractory, whatever your measurement of choice is for cardiovascular health, if you're becoming into issues with HIE, actually, you could use point of care ultrasound to look at the adrenal gland to see if you've got a hemorrhage, and if you have, then actually give steroids because in those babies. And also in particular in septic babies, it's well documented you can get adrenal hemorrhages, and actually you can get a lack of the steroids will help from that point of view. And certainly in some cases, and some people I've spoken to, they've given steroids to these babies, and it's worked like magic. And other inotropes they've been able to come off because they've had interference perhaps with their steroid production. So yes, I would be very cautious, in particular with I'd say the natural catecholamines, in particular, like noradrenaline and adrenaline, about higher dosages. And if you are getting into that range, think of something else or think of steroids.
Aaron?
Yeah, hi, this is Aaron Mukherjee, one of the neonatal consultants at St. Mary's Hospital in Manchester. I'm terribly sorry, my camera is not working. Liam. Liam, it's a fantastic presentation. I thought to actually talk about all the anatropes in 40 minutes, I don't know how you managed that in the first place. So I think it's brilliant. I have a comment to make more than anything else. Quite rightly, as you alluded to, I mean, the fact that as neonatologists, we look after babies from gestation of 22 weeks through till 40 weeks. The fact that the metabolism, the pharmacokinetics and the pharmacodynamics of most of these medications that we're using on these babies vary a lot, and how these medications are going to be handled by the body in a preterm population, extreme preterm 22-weeker versus a baby born on term. I think we seldom talk about, the use of anatropes and the risk stratification according to the gestational ages. And the problem with that is, as we all know, the problem is one size fits all always becomes a problem. And I'll give you an example. A 22-weeker with a nasty respiratory distress syndrome with PPHN started on adrenaline and milrinone, because that is what PICU normally does, is something which has been taken over by some of my consultant colleagues in my hospital. Well, let me just give you the background. I work with 23 consultants on our rota. We are a pretty big unit. And the problem with that is that it starts raising alarm bells as to a very small preterm heart with very little reserve, how it is coping with high-dose adrenaline and milrinone, which are primarily tested on term babies with, say, meconium aspiration causing PPHN and that kind of thing. So I think if we keep talking about all these inotropes with a particular condition, that dopamine always causes, if there is a risk, dopamine can cause pulmonary hypertension, so people should be cautious. Actually, low dose dopamine of actually 10 mics per kilo per minute in a baby with a PDA hypertension, which is probably a 23-weeker who's otherwise all right, has got a wide pulse pressure, probably the diastolic pressure has dropped down quite a lot, needs a little bit of a vasoconstriction, can work favorably for a day or two before before things get sorted, maybe with the PDA treatment, or if we look at it otherwise. It's just how we interpret this in the light of the different gestational ages, and whether, and I just wanted to know what your thoughts were. Thank you.
Thanks. Yeah, it's a really good comment. It's a really difficult question to answer, because and the simple answer is more research, but that's not a very good answer. But I think what's difficult is that again, that's why I said read the mid trial. I think is really interesting. I think there's an interesting editorial which goes with that as well, in that particular issue where they publish mid trial, is that you've got so many different etiologies that can lead to what the particular condition is. You've got so many different gestational ages, and as you rightly mentioned, you've got the different issues you have with the pharmacokinetics and pharmacokinetics of each baby. In that, the possibility of creating an all-encompassing trial which includes all of these different etiologies, different gestational ages, is going to be very, very difficult to do. But if we do want to look into these really powerful drugs and do it, it's going to take a collaborative kind of effort over multiple different centres. And that when you almost do bring a baby in, if you've got a baby, when a baby comes into that trial, and let's say you are creating a trial where you've got the physiological braced approach, the use of echo, for example, versus just a treatment protocol approach, for example, that actually I think the trial would have to be very wide in terms of defining what that baby's problem is, and then that baby almost being siphoned off into a certain arm of the trial which deals with babies who have got poor transition, for example, versus the baby who's been born septic. But again, the numbers would have to be really, really big for this. But what is interesting is if you have a look at other specialities like pediatric oncology or oncology as such, or in that actually they have multiple arms to their particular trials. And if a child on their oncology journey doesn't go down a different, it has to deviate from the protocol because they're not neatly fitting into the box as such for that protocol, that trial, they allow for that. But it's really difficult. And it's going to take a lot of babies. Our population is relatively small, and being able to recruit into such a trial when you have lots of other competing trials as well is difficult. My honest answer is that I don't think this is going to be something that gets solved, for a very, very, very long time, and that we're going to have to rely on more anecdotal evidence, or not anecdotal, but evidence such as the study from noradrenaline, for example, which looked into septic babies, for example, which was well thought out, was very diligently done, but is in the end it's a retrospective study, and that's why I feel like we're going to get the evidence in the shortest term. Long term, it's going to take a lot of effort from the whole neonatal community across borders, and I think that's a really, having tried to do that as part of the near circulation trial between Brighton and Madrid, 2 centres, and how difficult that was, being able to do it with multiple centres. I think something like the Benedictus trial is an absolute triumph in how they actually managed to get that trial done over so many different centres and stick to that protocol. But yeah, I haven't answered your question, but it's the best answer that I could come up with.
Thank you, Liam.
Great. I think we already passed 1 o'clock. So thank you very much, Liam, for this fantastic talk. Thanks everyone for joining. We'll upload the recording later on, so we'll see you next week. Thanks everyone. Have a good weekend.
Thanks a lot.
Thank you. Bye-bye.